Good morning. Again, I'm Jen Woodward. I'm very excited to be here today and to have just joined our next speaker at Memory Center Charlotte. So I'm very excited to introduce Dr. Charles Edwards, who's a Charlotte native. He grew up in the Sedgefield community. He attended college at UVA playing basketball, and anyone that knows him knows that he likes talking about basketball probably more than he likes talking about medicine. But he did go to medical school at UNC and then completed a residency at Duke in cardiovascular surgery. And he worked for 30 years as a cardiovascular surgeon in the Charlotte area. He was greatly impacted by caring for his elderly parents, both of whom had dementia. And so in 2013, he opened Memory Center Charlotte, which takes a very innovative approach to caring for patients and caregivers who are affected by dementia. So please join me in welcoming him to the stage, Dr. Charles Edwards.
Jen, thank you. And Heather, thank you. That was an awesome presentation. All right, we're going to get started. This is going to be a little bit different. Jim, am I ready to go here? Huh? It's not moving. It moved for her. I know, I didn't think I'd be discriminated against this much so early. There you go. So a little bit strange, but this is a picture of John Keats. This is the title of my talk is When I Have Fears. And the title comes from Keats, who wrote a poem in 1818 called When I Have Fears That I'll Cease to Exist. And the poem was inspired by the fact that tuberculosis had devastated his family through generations. He lost his mother in 1810. And sadly, the year after he wrote this poem, he would have his first bleed from tuberculosis. And then in 1821, he would die at age 25 of TB. What does this have to do with Alzheimer's? Well, this kind of was a signal to me that there were two themes from reading this poem and realizing what he had gone through. One is how terrified he must be, or he was when he had those bleeds. And he knew as soon as that happened that there was no hope, that he was going to die of that disease. Also, it sort of struck to me that we have dealt with these kind of diseases forever. We had the bubonic plague in the 14th century that killed 1 out of every 3 human beings in Europe and half the population of China. We then had smallpox. We had tuberculosis. We've had AIDS. But in each of those instances, because of the perseverance of researchers and the brilliance of scientists, we were able to impact them. We were able to cure bubonic plague with antibiotics. Smallpox, we eliminated it from the face of the earth with a vaccine because of Jenner and looking at those milkmaids. But now what strikes me is that the fear comes down to now we have a plague, and that plague is Alzheimer's disease. Because of the fact that when Alzheimer's made the diagnosis in 1905, we today can impact that disease no more as far as cure, prevention, or delay than he could in 1905. So we have some challenges, and some of that we have some hope. So today, what we're going to do is we are going to look at normal cognitive aging. The more you know about what happens normally, the less fear you can have. Second, we're going to look at the risk factors for dementia. What is going to set me up for getting this? And if I can know what the risk factors are, I can stop it, hopefully. 3 is we're going to review the science. Just like Heather kept saying, the science, the science. Fear needs facts. People can sell you a lot of stuff when you have fear. You can get off on the wrong track. Science brings us back. And the 4th thing is we're going to look at some practical strategies for incorporating the science into our lives. Okay? Jim, you want to set that off for me? This is an artist's rendition of a young baby. Her name is Danielle. and you're going to watch this sort of amazing aging of her. Now, it's impossible to think that the changes that are occurring in this woman's skin, the thinning of her hair, the coarsening of her features, and the wrinkling of her skin is not causing problems in her brain. We have these changes that occur in all of us. And what we're going to do is kind of, next slide. I got it. Okay, sorry. So what we're going to talk about a little bit is two forms of intelligence, okay? The first form is called fluid intelligence, okay? Now, fluid intelligence is the capacity to reason and solve novel problems without any past, any knowledge from the past. That's fluid intelligence. This is where IQ comes in. You take that small child, you give them the puzzle, and they just go. IQ. It also where math is. It's where solving puzzles. It also is where TV remotes come in, okay? The second one is called crystallized intelligence, and it's very important because this is where we get our confidence, because I'm going to destroy that confidence in just a minute. But crystallized intelligence represents a lifetime of intellectual pursuits and achievements. It largely through vocabulary and general knowledge, but it increases with age. It is primarily what wisdom is all about, okay? So we are going to look at this picture of Danielle. In fluid intelligence, we peak at age 27. That's where she is right there. At least I picked it out. These are the Salthouse intellectual studies to show you that from age 20 to 90, what happens in every single category of fluid intelligence? We go down dramatically. So those guys walking on the street with a hat on backwards and they look like they have no idea what's going on, you set them down to do a puzzle, they're going to beat us. They're going to do better, okay? So every day in the clinic, not every day, every week in the clinic, I have people, sometimes they're my friends, sometimes they're just acquaintances, but they come and they say, Chuck, I'm losing it. I said, what happened? Well, about 3 nights ago, I left the refrigerator door open all night long. My wife came down and went nuts. She just went nuts. She said, you're losing it. You got to go see Chuck. And he said, I was okay with it. I said, no, it's just a mistake. And then I did the exact same thing the next night. So that's why I'm here. He said, also, the reason why I'm here is because I've played golf with the same 4 people for the last 20 years. And when I was playing on Saturday morning, I had to look at the tags on their bag to remember their names, okay? It's called subjective memory loss. You think you're losing it, but you're not. So when we tested him, he tested fine, just a little distracted, maybe hungover. But what does subjective memory loss look like? As we age, we have to become a little bit more aware of what we want to remember. We have this giant Rolodex in the back of our minds, and we're 27 years old. We absorb it. Everything we see is just put on that Rolodex. But when we're 65 years old, that Rolodex has a bunch of crap on it, and we can't get it back in our minds. So we have to be much more aware of what we want to remember. 2 is always processing time slows down. When your 11-year-old grandchild takes your cell phone away from you and does it and hands it back before you even know what's happening, that's what slowing the process down is, okay? 3, names. People come to me all the time and say, I can't remember anybody's name. I don't really care about names. We lose names. Oftentimes I'll ask them, I'll say, you were good at names? Oh, no, I've never been good at names. I said, well, why in the world would you think you're going to get better at it? Okay. Multitasking. We really lose a lot of our ability to be able to hold one thing in our minds, go do something, and then come back. It's just built in that we are not as good at that as we age. And it really frustrates people because you come back and you go, wait a minute, what was I doing? And you can't remember, okay? If it happens all the time, you might need to come see me. Sensory overload is what I was talking about. There's a bunch of junk up there in that in the brain, and we haven't triaged very well. So therefore, we're thinking about the flowers on the table, and we forget the lunch, okay? So we fill our minds full of very small details that oftentimes don't matter. New knowledge, especially technical. I think technology has changed aging. The reason is because it used to be that you had a grandfather and you wanted to know what your grandfather had done, and he was a symbol of wisdom, okay? Now, to my grandchildren, I'm the old guy that can't run the iPad as good as they can, okay? So their respect for me is down. I mean, they get the eyes rolled and all that kind of stuff. So, but we have to understand that what happened to Danielle going through that menage is what happens to our brains. And we have to accept it. And we have to address it. Okay? All right. So what is the hard science on risk factors? What are the things that we can prove that show that that they're involved, it's going to increase the incidence? The first, as Heather said, is age. Alzheimer's and related dementias, Alzheimer's specifically, is a disease of aging. The incidence at 65 is lower than it's going to be at 85 and as we age. Peter Rabins, the famous psychiatrist at Hopkins, feels like if we all live long enough, we're all going to get it. I hope that's not true. I don't believe that. But age is a major factor. Genetics. All right, so there's no way around getting your DNA, around your DNA. You can be really proud of the fact that you've got your father's cobalt blue eyes. You can look at him in the mirror and say, wow, Dad really helped me out here. And then you got to realize that you got your grandmother's rather chunky thighs, okay? So I knew that joke wasn't going to go over here. I knew it. Heather, you warned me. I know. We were going to do wide feet, but it just, okay. But I know. All right, so forgive me. All right, forgive me. A little sexist there. But the point is that we can't get around our DNA. It's the one thing that we can't alter. But having said that, having had two parents that had Alzheimer's disease, there is lots of data to show that actually our life experiences and the developing lifestyle changes and things can trump genetics. And that's what I'm all about, is trying to trump my genetics, okay? Third thing, education. Education, if you have a high school education, you have a lower incidence of Alzheimer's disease of people who left high school before graduation. College degree trumps the high school degree, and then a professional degree. Each one of those education elevations decreases the incidence of Alzheimer's disease. Now, unfortunately, when you start to decline, you all decline really at the same rate. But education does protect you, and you'll be interested to know that it even includes the University of North Carolina. Cardiovascular risk factors. It's been an exciting time for this. There have been 2 articles in the last, since November in the New England Journal. But the one that was most exciting was the Framingham study. Harvard Public Health, School of Public Health, adopted a town in Massachusetts called Framingham. And this is where all the data came from for controlling hypertension, cholesterol, and how it would impact controlling diabetes, how it would lower the rate of heart attacks and lower the rate of stroke or heart failure. And it's been amazing because as they treat it aggressively, the incidence of these things have come down in our society. So they went back and looked at this data. And as we altered the cardiovascular risk factors in successive decades, the incidence of dementia went down. Okay, so cardiovascular risk factors, treating hypertension aggressively. The second study showed, it's called the SPRINT study, that 120 was much better than 140. They had to stop the study early because the people at 140 had so much higher incidence of stroke and heart attack. My only reason for mentioning this is that when you go to the doctor and your blood pressure is 160, and he says, well, you're just a little nervous, and we're just going to, no. I want my blood pressure down, okay? It's not good enough to just keep going. And in those patients that keep ignoring that, the stroke rate and heart attack rate are enormous. Lots of studies. So I want you to challenge your primary care. And don't tell them I said that, okay? Because medications, two major medications that I don't like unless we have to use them. One are benzodiazepams. If you look at a group of people that have been on benzodiazepams, Xanax, Ativan, Klonopin, Valium, Versed, they have an increased incidence of dementia, okay? Now, they're great drugs because they make you high and calm. Who wouldn't want to be high and calm? You know, but the others are the atypical antipsychotics that we use for people with schizophrenia and things like that. There is an increased incidence. All right, here's traumatic brain injury. We already talked a little bit about that, but now we're learning about concussions. We've actually always known about them because of the boxers. Look at poor Muhammad Ali. What a magnificent man, and just, you know, Parkinson's and that dementia ate him alive. But we're starting to become aware of repeated concussions having an effect on younger people, okay? It's going to affect whether or not you let your grandchildren play football. All right, here's the emerging science. My buddy Dr. Weeks thinks everybody has sleep apnea. They probably more than we know have it, but the injury that occurs at night if you have true sleep apnea is additive. Also, if you're not sleeping, memories are stored while we sleep. So sleep is incredibly important. And people love to say, I only get 5 hours of sleep. And I go, why would you say that? I got 9 hours of sleep, and they had trouble getting me out of bed. I mean, you need sleep. It's where things become calm and clear. The second thing, and this is huge, is hearing loss. We test everyone in the clinic for hearing. If you look at large studies, people that have mild cognitive impairment and have hearing loss will deteriorate at a much faster rate, okay, much faster rate. We have actually had people come to the clinic, which we thought they had early Alzheimer's. We got them hearing aids, and the next thing we knew, they were back and tested normal. So hearing loss is a huge risk factor. 3, there is a study called the Religious Order Study. It's not really the nun study. The nun study was a little bit before that, but it's the Religious Order Study. And what they did is these nuns, Order of the Blessed Mary in Wisconsin, donated their brains to science when they died. And so they were able to look at the profile, the social profile of the nun when she was living, and then compare it with the pathology at the end of their life when they could actually see under the microscope with the plaques and tangles that Heather Snyder showed us. So what happened was they started to see this pattern that a lot of the nuns had the exact same amount of amyloid in their brain. But several of them did not get Alzheimer's disease, and several of them did. And they looked at the social profile. The ones that had a large social network, 10 confidants or more, were less likely to have it. 2, the ones that were, quote, conscientious. My father's going to love this because he always said I was kind of a sort of a dizzy guy. I wasn't conscientious enough. This scares me. So being conscientious, being connected, having a lot of joy in your life can protect you from Alzheimer's, at least in the early data from the Religious Order Study. Depression. Depression's a sneaky guy. And when you are 25 years old and someone looks at you and you have your body habitus down and your facial physiognomy is depressed and masked, you say, that guy's depressed. And yes, he is. As we age, depression presents itself very differently. It is irritability, it is social isolation, it is apathy, it is anhedonia, things that I used to love to do. I don't want to do them anymore. They don't give me any pleasure. So depression comes into your life a little bit different way. Also, this macho thing about, I don't need any medication. Well, we're not trying to make you into a different person, but if you are down and having negative thoughts, it's going to translate into some bad things in your life. And all the medication is supposed to do is to kind of put you back to normal for a short time so you can get your own good mojo going. All right. How we get fooled in diagnosis. We want to make a diagnosis early because then we can recruit resources, we can help caregivers, we can help the patient. We can actually, in mild cognitive impairment and early Alzheimer's, give them tools to be still functional. When we look at what they are, let's say that they have parietal lobe involvement and they're disoriented in space and they're driving down the middle of the road and not looking at the lines. We've got to take their license away. But there are ways that we can address if we know. But the single biggest problem of making an early diagnosis is, one, caregivers not wanting to go down this, and two, the most important is resistance on the part of the patient. There is an underlying fear in all Alzheimer's patients. If I admit that I'm losing my memory, or I admit that I'm struggling, then I'm going to be alone, and I'm going to be somehow put in some kind of home. So the resistance and the anger. So someone comes in and say, I've been struggling with my wife. She's been losing. But every time I mention it, it's like World War III. So the resistance, we've got to overcome that. Okay. Two is social skills. You've had this happen. You're at a cocktail party and you're with this delightful 95-year-old lady and she's telling you a story and you go, wow, I hope I'll be as sharp as she is when I'm that age. And then you turn around and she tells you the same story again. And then all of a sudden okay, I got it. But cocktail parties, 5 minutes, anybody can fool you. Distances. What's happened to our culture is that it used to be that grandparents lived next door. And so they were part of things. And having that connection may have kept them sort of in the road. But now distances. The husband dies and mom lives in Seattle. And you think mom's doing fine. And you really can't visit her very often. And then you go, and she's been there for 3 to 6 months. And you go, and all of a sudden you go and you open a refrigerator, and you know immediately that things are not good. Okay, but distances. The other thing, even if you live in Charlotte, and you call your parents on the phone, or call a sister or a brother, and they'll fool you on the phone every time. Okay. So phones cannot be trusted. You got to go. You got to be near them. Okay. Am I doing okay on time so far? Am I? Okay. All right, prevention. In the early 1990s, a group at the Karolinska Institute in Stockholm developed or found in mice a substance called brain-derived neurotropic factor. Okay? And it was larger in mice that were bred to exercise. So you had a link between the observation that people made of people who are exercisers not getting dementia. Now, I'm slow to come in this because 5 to 10 years, oftentimes before you develop dementia, you get apathy. And so my feeling was, and I was at Hopkins, I told him that, I said, how many times have you seen an apathetic person in a gym? It just doesn't, if you got apathy, you're not going to say, hey, come on, let's buck up. Let's go do some push-ups. What? What are you talking about? I'm apathetic. I don't want to do anything. So, but brain-derived neurotropic factor and the other trophic factors are the key to what happens when you exercise. So if you take brain-derived neurotropic factor, what it does is it actually is centered in the hippocampus, which is the place where Alzheimer's starts in our brain. We exercise, brain-derived neurotropic factor is actually higher in the hippocampus. So this is the link. If you take brain-derived neurotropic factor in a petri dish and put it on a neuron, they start to grow, these interstices and the dendrites. So it is miracle grow, as John Rady calls it, miracle grow for the brain. The best data, exercise. 2, treatment of medical diseases. We have diagnosed in the clinic multiple patients with hypothyroidism, pernicious anemia. We've had 4 pacemakers put in the last year in our patients. They come and their heart rates are 40 and they're sort of demented. Well, then they go and get a pacemaker and they come back and they're Albert Einstein. So there are medical things that, one of the things that is kind of scary to me is we have diagnosed malnutrition in several women that live in these big houses here in Myers Park. They're not eating properly. They are, when they come in and they're got these sticks for legs, I know I'm in trouble. Okay, I know I'm in trouble. Social interaction. We know from the nun study or from the religious order study and also from catalogs of data that people who have lots of people in their life are much less apt to get, this is soft science again, emerging science, but the more people you have in your life, the better chance you have of avoiding it. If a classic education protects us, then, and this is my bias, and I've had it for a long time, is that for our generation, Lumosity and PositScience.com and watching those things bounce on the screen, it's not going to help you. It's not. First of all, it's, now my grandchildren, when they get to be like this, yes, that might help them, but not us. So what we have to do is, classic education is taking a subject and mastering it, taking a course, or reading voraciously, fiction. If you're reading fiction, your brain lights up. You know, if you are reading about skiing down the slopes in the Alps, or you're reading about falling in love, and you have an MRI, a functional MRI, the places in your brain where love lives, it lights up. So being very active in trying to get new knowledge, coming to things like this, because nothing will stimulate your brain like new knowledge. Okay, I got 2 minutes or 5 minutes. Okay, I'm good. Diet. I'm not a supplement guy, okay? There are 2 vitamins that we don't make as we age. One is vitamin D, because we got that thin skin and we all got sunscreen on, okay? And 2, B12. We don't absorb it as well. So those are our 2 things that we really are aggressive about. But patients come in with these stacks of all of this stuff where there's no data to support it. But getting those same nutrients in food is effective, okay? But just taking a bunch of pills kind of goes right through your system, okay? So diet is going to be the next, and I don't have quite enough time to go over a couple of studies on diet, but diet is very important, and it's also going to be the new frontier. Okay, all right, so I'm sure everybody's interested in this. Personal philosophy, transitions. All right, transitions are when your external reality has changed irrevocably. Things are not going back to the way they were. There are soft transitions. There are aging to where you can't play golf anymore just because your knee hurts or whatever. And 2, a soft transition would be a retirement. A hard transition, caregiving for a patient that has dementia. 2, a traumatic injury that abruptly stops. Or a death of a spouse. So how we navigate transitions. Someone retires, and then all of a sudden they're at home, and they were a big shot down at the bank, hard charging, and the next thing you know, they're sitting on that couch wanting to see when 5 o'clock comes. If we can, 1, convince that person what they did at the bank or what they did at Presbyterian Hospital for 30 years wasn't necessarily that important. We need to put a period at the end of that sentence and then start a new life over with new goals and a new culture. This is very important because I see if you can't navigate the transition, you're going to end up alone and you're going to end up not having a very joyful life. Okay, PTSD. I got 2 more minutes? I do? Okay. It's my conference. Really, I can take 2 minutes if I want. All right, PTSD. You've read a lot about it. What PTSD is, traumatic events in our life changes the chemistry in your brain forever. So your behavior and your perception of the world has changed irrevocably. Now, if that's true, then we can flip that. Okay, we can flip it. Instead of it being a negative, we can actually make it a positive. Because if we see the world in a positive way or interact in the world in a positive way, then the chemistry in our brain is going to start letting us see things in that, and we're going to have this really good chemistry going forward, okay? So PTSD means that the external world, when you perceive it, changes your chemistry. So therefore, we're going to use it to be positive. I want to make sure that I'm not forgetting something here. My last thing I want to talk about is the concept of wonder. Wonder is the innocent and uneducated, or the awe, associated, free of cynicism and judgment, associated with interaction with the world. Think about when you saw Alan Shepard or John Glenn go into space. Do you remember the innocence and just the absolute awestruck that you were that we could do that, okay? Well, in our everyday lives, our lives are filled with those still awe-inspiring things. The magic is there. We just have to stop and not be impatient, angry, detached. What we have to do is participate in it. But if we recognize it and we participate in it, the science behind preservation of Alzheimer's is on our side. So having positive thoughts might prevent us from Alzheimer's. Wow, wouldn't that be awesome? Okay, thank you.